Okay, you can start now.
Okay. Yeah.
Okay, good evening.
Good evening, doctor.
I'm Dr. Satish, one of the child doctor, and I believe you are Anu, and she is your daughter Tanya, right?
Yes, doctor, this is me.
Okay, thank you for coming in, Anu, and you can have a seat. How was your journey to the hospital?
It was fine, doctor.
Okay, I got this letter from GP that Tanya is having again this is leaking protein in his urine, which is seen by the reports. Is that right?
Yes, doctor. Actually, last week she had fever, and then now from 4 days I see that some swelling in her eyes. So I
Okay.
was instructed to do the protein dip test for her. I did,
Okay.
and I found 3 cross proteins in her urine dip. That's why I went to the GP and he referred me to you.
Okay. Okay, Tanya. Okay, Anu. So, can you elaborate how it started first? How till when she was fine and she started having problems recently?
Yes, 4 days only, doctor. Now she was fine before that. Last week she had
Okay.
some running nose, some mild grade fever, for which I did not do anything. I just give her paracetamol and some nasal drops. She was fine then, and suddenly from 4 days I see her eyes swollen. Since before she had nephrotic syndrome, I was instructed by the GP before that whenever you see some swelling to do this urine test. That's why I did for her the urine dip at home.
Okay. So, like last week when she had this fever and this, how was the fever? How severe was the fever?
No, it was not very high. It was just mild, 38.
Okay, it settled on its own, or you need to give any medicines?
No, only paracetamol was given for 2
Okay,
days.
okay. Then she also had a runny nose.
Yes.
Okay. Besides this, she had any problems with her urines, pee?
No, doctor. No, there is no other problem. Only I feel there is puffiness in in her face.
Okay. So, like last 4 days, you have noticed she is having a puffy eyelids. You have noticed before also because she had nephrotic syndrome last year. So how it is going on? It's increasing, or it's like it's same from the first day onwards?
It is it's increasing every day. I feel it's increasing every day.
Okay, so it has but now can you see this swelling in her tummy?
Mild swelling, doctor. Yes, there is mild swelling in her tummy.
Okay, and in the legs also, have you noticed swellings?
Yes, there is some swelling.
Okay, so is she complaining any difficulty in breathing after the swelling has increased?
No, doctor, no difficulty in breathing.
Okay, it's she complaining tummy pain?
No tummy pain.
Okay, and have you noticed any swelling in her private parts?
No, doctor, no swelling.
Okay, so have you noticed anywhere like she is really tired and she's not doing work and she's complaining for headaches like that?
Yes,
Anything?
yes, she has headache. She holds her head. She holds her head when for some time, and she says she has headache. And
Okay.
after some time, she will be fine. Like this, she's doing. She has headache. Yes.
And what about her? Like I also got to know that she has some pressure problem this time. Have you recorded this high BP before also?
No. Last year, her BP was fine. Only this time there is a problem in her BP.
Okay. What about her vision? Is she having any problem with her vision?
No, doctor, no problem with vision.
Okay. And beside that, is she having any way rashes?
No rashes.
Okay. And have any joint swelling?
No joint swelling.
And this swelling in her limbs, have you noticed any day this ulcers or any infections like these things in her limbs and anyway?
No infection, doctor.
Okay. Okay, Anu. And I want to know, how was the doctor in last episodes, how it was diagnosed as a nephrotic syndrome?
Yes, doctor. Last time when she was 6 years old, the same thing. She had some flu-like symptoms before. Then
Yeah.
after 2 weeks, she developed like this, the same way, like how she's presenting, with puffiness of face, some swelling in tummy, some swelling in legs, like this. I thought she has some allergy. I gave her some medication at home myself. I don't remember the name, some anti-allergy medication. I did not see
Okay.
any response. Then
Okay.
I went to the GP. My GP did urine dip, and he said there is 4 cross proteins in her urine.
Okay.
And then he referred me to the doctor. I mean, to the children's doctor, and
Okay.
there they said he needs admission. Then he was admitted, and they gave him, they do some blood tests to him, and then
Okay.
they gave him steroids, a
Okay.
course of as I remember, maybe 2 weeks, and then
Okay.
they reduced the course, and then
Okay.
she was fine.
Okay. So it was okay with the steroid. You don't need to give any extra medicines, and right? Am I right?
No extra medicines, doctor.
Okay. Did doctors use any medicines to increase urine, like some kidney urine making medicines like Lasix or anything?
No, doctor. No, no, it was not
Oh,
used.
was she given any proteins by the this IV, this through the veins?
No, they told me that will give steroids and they will observe her. If there
Okay.
is no
Okay. Okay.
response and if she
Okay.
needs, they will give.
Okay. Okay. Okay.
And
That's
they said they are monitoring, and presently she was not sick.
so. How long they used this steroid medicines? Do you remember?
Yes, 2 weeks they gave every day. Then
Uh-huh.
I think they started reducing, but I don't remember exactly how. Now I have forgotten, doctor.
Okay. Was you given steroid card that time?
Uh,
Corticosteroid card.
I don't remember, doctor.
Okay. So, and in between these days, she was perfectly fine, right?
Yes, she was perfectly fine after that episode. And
Mm.
now again, she has this problem.
Okay. So, do you remember at that time she had high pressures?
No, she did not had high pressure.
Okay, good, good. Okay. So, after this, in this episode, I want to know about what about her urine output? It is reduced markedly, or it's usual?
Uh, she,
9 minutes over.
okay, she's passing. Okay, doctor. I don't think it's much reduced, but I can say slightly reduced.
Okay. Is it color is very red? Have you noticed like blood or like
No,
blood
no,
like color?
no blood, no blood in urine.
Okay. And does she have any chronic illness for which other than this problems for which
No
she was
chronic,
taking medicines for a long time?
no other chronic illness.
Okay. Okay. She has no problem with her heart, right? Anything
No problem.
doctors have said?
No
Okay.
problem with her heart.
And then has doctor said any problem with her liver or anything, Tommy?
No problem with liver, doctor.
Okay. Okay, that's really nice. And Okay, it will be little very past questions, but do you remember, do you want to share anything about her birth that is very significant you want to share?
No, doctor, her birth was normal, and during pregnancy also nothing was there. Her birth weight was 3 kg, and she was
Okay,
fine after that.
okay. So have you given all vaccines?
Yes, doctor, vaccinations is up to date.
So have you given this extra chickenpox vaccines?
Yes, doctor. Actually, she had received her regular dose of chicken pox, and it was checked whether she received or not.
Okay,
Or
okay,
she
this
was
varicella.
pregnant, so nothing
Okay,
was given.
okay. It was, doctor said it is the immunoglobulin status was normal, right?
Yes, I don't know. Maybe they did some blood test. They said
Okay,
not required at the moment.
okay. What about her developments? Like, do you have any concerns? She's 7 years old. How
She is developing as according to her peers. No problem.
okay. What about her studies? Is doing good, going good?
Yes, doctor. Now she is in the grade 1, and she's
Okay,
doing fine in the studies.
okay. Does the conditions impacted her studies?
Yes, now you see, she did not go to school today, and from 4 days
Okay,
also she did not go because she was not comfortable.
okay. So how many kids do you have?
I have three kids in total, including Tanya,
Okay, she is the youngest one, or who is?
eldest. She's the eldest.
Okay, okay. Do you have two younger kids? So who are looking after the younger kids when you have to take care of her? But do you have any issues regarding the care of her other babies?
Yes, doctor, when I have a problem because uh, no one to take care of my kids, I leave them now with my neighbor and I have come.
Okay. What your husband do?
He's an engineer, and he doesn't stay with us. He works in a faraway
Okay.
place.
Okay. So how it has impacted, this illness is impacted her, Tanya, and you as well as a family? What do you
Uh,
think?
No, last year when she was sick, she was admitted for 2 3 days. I had to take the help of my neighbors, and there was one nursery also. I used to live sometimes with neighbors, sometimes with nursery, like this.
Okay.
Now again, I have to think over how to manage.
Okay. How you are managing financial issues?
Yeah, my husband will send money from there. Uh,
Okay. Okay.
so I don't work. I am with the kids.
Okay. So do you have any family history, any kidney problem in your side or in your family, in your husband's side?
No, doctor, no problem.
Okay. So Tani, so Anu, this what do you think, like why this problem has do you have any idea you want to share
No,
about the
no,
Tanya that
doctor.
I have not asked?
No, I don't know. I think you asked everything. I think she got fever. That's why again this problem came. I am not sure.
Okay. Okay, Anu, thank you very much for your information. I will get back to you after uh, I will be talking with the consultant. Is that okay?
Okay, doctor.
Okay, thank you.
Yeah, time is up.
Okay. Alhamdulillah, you finished in time.
I need to finish in 13 minutes actually, because 1 minute I think they are giving just for this technical issues to check for the technical and all these things. They have mentioned somewhere like that.
Maybe I am not sure. Better to keep it 9 plus 5. Means it was
Yeah,
before 13 minutes, right?
yeah. 9 plus 4, 13 minutes. This is ideal.
Anyways, no problem. So let's continue now. Can you present your case?
Okay.
Keep 9 minutes, Dr. Deepa. Okay, present.
So I took history from Anu. Tanya is a 7-year-old girl diagnosed as a nephrotic syndrome when she was 7-year-old, which was treated with the steroids and as a steroid sensitive nephrotic syndromes. And since last 4 days, she is having puffy eyelids and lid edema, which was preceded by the fever, likely of the viral URTI, for which she was given consulted a GP, and she was prescribed with paracetamol. Recently, this puffy eyelids and lid edema has increased, which has been with the swelling of the abdomen and in the legs. She doesn't have tummy abdominal pain, no chest discomfort, no genital edemas, and she is complaining for headache. Though like it was recorded in the BP's note also, there is a one reading of hypertension, which was not there before in the last episodes. And she has been vaccinated with the she doesn't have fever, this rash, arthritis, or other systemic findings. And then her birth history is not significant. She is vaccinated with all vaccines, with chickenpox vaccines also given, and her serology looks looks likely to have been done in the last follow-up, which was okay. Developmental milestones is okay. Family history is insignificant, except that she is her father is not staying with the family, and she has issues with the caring of the 3 kids, and as she has 2 other younger kids. And so with all this history, my diagnosis will be first relapse of steroid sensitive nephrotic syndromes without complications.
Okay, so your diagnosis is relapse of the steroid sensitive nephrotic syndrome. So what else differential diagnosis you want to put?
My differential diagnosis would be it will be angioedemas.
Okay.
And then nephritic syndromes.
Okay.
Nephritic syndromes. These 2 I would like to put.
Okay, what else you want to put, and what else can be the differentials, and
okay, congestive cardiac failure and the liver failure also can be the cause of this
cardiac failure
SIT.
and chronic liver disease.
Chronic liver disease and then congestive cardiac failure.
Did you ruled out this from your history, the congestive cardiac failure and chronic liver disease?
I just asked any chronic
yeah, you are
kidney
problem with liver,
yeah.
Any problem with heart, you will not ask like this. Okay, we will discuss
last time also I did same thing. Yeah,
the same thing. So okay, so these are the differentials: angioedema, nephritic, congestive cardiac failure, chronic liver disease. So tell me your management for this patient, investigations, and how do you proceed with this patient?
First of all, I would like to take the detailed history. After taking a detailed history, I'll do a complete examinations, including the blood pressures, and then I will look for the hydration status, and look for any tachycardia. Is she in shock or not? And then then I will. If she is not on any, if her vitals is okay, and if she is not in shock, I will start prednisolone at 60 mg per meter square. Once daily until the when she goes into the remissions with the 3 less than trace or nil proteins for 3 consecutive days, and followed by a tapering dose of that 40 mg meter square alternate days prednisolone for 4 weeks.
Okay, 60 mg prednisolone you will give till you get the remission.
Yeah.
Okay. So what investigations you want to do?
On relapse, I would like to do I would like to rule out any new infections with this complete blood counts and CRP, and look for this protein serum albumin level, and urine albumins, and also I want to look for, because I want to confirm this urine leaking in the hospitals also, in my hospital also.
So you want to do urine analysis,
Urine analysis to look for this proteinuria, and if since there is hypertension, I want to look for hematuria also, if there is any microscopic hematuria or not. And then I would like to do a serum albumin, and since, and then to rule out these acute infections, I would like to look for this complete blood count and CRP and blood cultures.
Okay. What about kidney function tests? Did you say?
Yeah, kidney function test also, yeah, because in relapse, yeah, we can do one.
And do you want to do zoster immune status in this patient now or no?
If not done before, then I would like to do zoster immune
Done 1
status.
year back.
I am not sure about this because it might fade, right? Yeah.
Okay. So now this child has hypertension. I mean, there are features of increased BP. Any other investigations you want to run?
If there is since there is high BP, I would like to do anti-streptolysin O, anti-nuclear antibodies, and anti-dsDNA.
Yes. Okay. Mhm. Okay. So if this patient was in shock, what was your management?
If this patient was in shock, I will consult with my consultant first. I'll inform the consultant and the pediatric kidney disease nephrologist if available, and I will give this first sodium chloride 0.9% 10 ml per kg, and I will also have to give the 20% albumin at 0.5 to 1 gram, that is 2.5 to 5 ml per kg over 3 to 4 hours.
Okay. So along with this, what you will give? Along with 10 ml normal saline and albumin, what else important thing you want to give?
After giving albumin, I will give a furosemide, Lasix.
Yeah, diuretic.
1 mg per
You will admit the patient. Where you will admit this patient?
I will admit in a separate cubicle because this
No, I mean ward or PICU. If you want to give albumin 20%, you will admit in ward or PICU.
I will admit in PICU.
Okay. So can you give me? Can you tell me what is steroid resistant nephrotic syndrome?
Steroid resistant is like if no response to steroid even after 28 days of high dose steroid is known as steroid resistant nephrotic syndrome.
Okay. Steroid dependent means?
This 2 consecutive relapse during the alternate day prednisone or within 14 days of stopping prednisone is known as steroid dependent nephrotic syndrome.
Okay. If it is steroid resistant, what do you do? How do you treat this?
In steroid resistant nephrotic syndromes, we have to go for a kidney biopsy and then contact with the I will first consult with the pediatric nephrologist.
Yeah, you will refer to pediatric nephrologist. Okay.
Time is over.
Okay.
Okay, and then I will start the steroid sparing agents like cyclosporins and cyclophosphamide.
Okay. So you will start or the nephrologist will start?
I think I refer to the pediatric nephrologist will be safe, maybe. And then what you can do if they ask, then I will say there is steroid sparing agents. This is immunomodulatory agents like cyclophosphamides and levamisole.
I am not sure that we will start or we will just refer to the pediatric nephrologist and he will be the one who will start all these things, I think, not we, because when you will give the basic treatment only, if there is failure, you will refer to pediatric nephrologist.
Nephrologist, yeah. I forgot to mention at the complement level when I had to say with the anti-dsDNA.
Yeah, the investigations, you will also
Second line.
no, compliments will come in baseline only. But I don't know if the relapse, if you have done before, again you will do it. I don't know how often you do it. Okay, you check that. But compliments, zoster immune status, all these are baseline baseline bloods.
IgG and IgM.
Wait, I will mute all, please. It was nice presentation, Dr. Satish, but I'm just asking you some questions because we don't know what questions they will ask, okay? Almost finished, maybe one or two I will ask. Just I want to know from you, when do you refer this patient to pediatric nephrologist? One you already told me, corticosteroid resistant disease, if no response. Apart from that, I want to know other causes when you will refer to him.
There is a age criteria, this less than 12 months and more than 12 years. And steroid resistant nephrotic syndrome, steroid dependent nephrotic syndrome, frequently relapsing nephrotic syndrome, and this hypertension and this renal failures, signs of renal failures, right?
Okay, yeah. That means nephritic picture also if you have with nephritic nephrotic picture. If you have mixed picture like macroscopic hematuria or creatinine, you test creatinine and it is very high, that is renal insufficiency and hypertension, all these things. And also you did the baseline and complement is low. That's why the complement comes in baseline investigations here. You did complement and it is low, you will refer, and also if it is ANA positive, you will refer. Okay. But Alhamdulillah, mashallah, you did good. You were good, but your only problem is you will not ask mother if they, instead of asking that she has a problem.
Yeah, this is my mistake. This is my problem.
This was the only mistake which was instead of asking any problem in liver, okay, maybe she can say, but ask her any yellowish discoloration of eyes, any problem in the heart or liver before. First, after asking the symptoms, still if you want to ask this question, but just don't ask any problem in heart, any problem in liver. No, ask some symptoms also, like
So main thing I realized today is like when I get a time for 4 minutes, I need to think of the DD and ask few questions for is DD also, because when I need to say the DD, when I had to say angioedema and I didn't ask about insect bite or allergies questions also. I realized when I was saying this at the time of differential diagnosis, and same with this liver and this cardiac. I could have asked about the
I have written here. You asked for rashes. Okay, rashes is acceptable for allergy.
Allergy. I asked rash, thinking of SLE and then this joint pain and SLE. So this rash and arthritis. But I didn't ask about this angioedemas when I was taking.
Did you and also related to the allergy, you did not ask about allergies to any medications?
That thing I asked, because differential diagnosis I mistakenly said differential diagnosis angioedema on the second line. So I was like, oh no, I should have asked these questions.
It happens. So write your, when you know that nephrotic syndrome, write your differential diagnosis in the site first to ask the questions in the history. So in the site you will write, okay, nephrotic syndrome, you know, you will ask. So for the angioedema, you will ask about the medication allergy or the insect bite or anything. Okay, and rashes also, it's okay to some extent in allergies. Some allergies present to you with rashes and also the edema around eyes. So it's okay. Rashes also is considered. Then for nephritic, you asked about blood in the urine, which is good. And also there is some component of hypertension. Now this time what the nephrotic syndrome is presenting, it's not normal. There is hypertension. So this child may need referral to nephrologist. Okay. Because there is hypertension this time. So you asked for urine, which was good for your nephritic. For CCF, you asked again heart.
Yeah, I think that. Do
You
you?
asked about shortness of breath. It's good. It's good. You asked about
That question I asked thinking of effusion only. I was purely concentrated on the pleural effusions, like no distress, because just to mention for the complications of nephrotic syndromes.
Yeah, but
And
still it's okay because you know, even in CCF there will be swelling, there will be
distress, yeah.
fluid in the lungs, and even in nephrotic syndrome you can get SOB. And this is not the main question. Your question was also right because apart from the shortness of breath for CCF,
palpitation, I could have asked palpitations.
yeah, any
That
awareness
palpitation
of heartbeat or anything. Apart from that, you have to ask, like any past history of heart problems, you have to ask, because just by this you can get SOB even in nephrotic syndrome. You have the swellings even in nephrotic syndrome, right? So even this question can be asked, but ask in past history, like any past history.
So I was also thinking of asking some questions regarding steroid toxicity, like do you feel she is getting obese or she has? I asked.
Yeah, but the
problem
thing
with
is,
reason.
the steroid was stopped for her almost.
Yeah, it was not given for a long time, so I didn't ask much.
Yeah. So it's not important here. Now it is stopped for a long time. Now you are restarting again. It's relapse.
Dr. Satish,
Also,
did you ask for this early morning urine protein create ratio?
No, this has to be done in investigation, I think.
Yes.
Investigations.
This is Dr. Krishna, this no need to ask, because this is not the part of the mother. This is the part of the doctor.
We will ask for the mother this question. Yeah.
No, in the investigation.
In investigation, I have to say like UPC ratio. Yeah.
But the initial, Dr. Satish, you should ask about how many days she has checked, because for 3 consecutive days to fulfill the criteria for the relapse, that should be 3 days. So you should ask for 3 consecutive days it's coming positive or not. One more thing, when mother said that she was on steroids and that was given for 2 weeks, maybe, I think so. So that should be asked, that you have stopped yourself or doctor told you, because usually they are giving for 4 to 6 weeks and they are tapering off on alternative
I was
days.
also
Then they taper off.
confused. Yeah, it is so this is not a
that should be asked. And how many relapses between this 1 year? This is the most crucial, because you want to, if you want to refer this child, so you should fulfill the criteria. How many relapses between this 1 year?
No, she said no relapse. This is the first relapse. I asked the question.
Yeah.
Okay. And
yeah,
again,
this
is not only just a blood pressure. We will refer at once. We will have to see this is, if it is persistent blood pressure, then we will refer. This is the persistent hypertension is the criteria. Refer to the nephrologist.
I asked twice this question, like blood pressures recording in last admissions, and this time only. But I didn't ask about like GP has recorded twice or a single time only.
But this is from the beginning only. This was a minimal change, looking like a minimal change. So I think the main, we have to focus on the main important things, like the daily weight monitoring, whether the mother was monitoring the weight or not.
Yes, they are saying that we should ask about the maximum weight of the child.
So I want to add 3-4 points we miss usually. The daily weight monitoring, avoid added salt. Okay, you should not advise a low salt diet. So these are the things, like, usually we should advise to any patient with the minimal changes. Apart from your history taking was very nice.
What we should do, Dr. Krishnan, low salt diet we should give or not?
Low salt diet, avoid added salt, no low salt diet.
Normal salt diet.
Avoid added salt.
Added salt has to be.
Yeah, on table salt should not be used.
Yeah.
Extra salt should not be used. Yeah. And yes, you did not touch. I wrote here. You did not touch the nutrition, weight, height was given, but still diet and any increase in weight was not asked. And yes, for the
so doctor,
For the vaccination, yes, only varicella or anything else also we have to ask.
Measles. Especially two vaccines should be asked in the history about the varicella and the measles.
Okay. And regarding the steroid card, Dr. Satish, can you tell me, you were asking about the steroid card?
No. I just read like steroid card and then this everything like in nephrotic syndrome steroid card and asthma action plan and the asthma card, the PFR, and it's like it fixed in my mind. I don't know about these things. This is written in red book. Like
yeah, you are right. Anybody who is
cardiac steroid card, they have written in the red book somewhere.
Yes,
I read yesterday only.
If anybody was on steroid, they have steroid card and they carry it with the steroid, this card with them.
Okay, I think you covered everything.
Complications should be asked more. Complications.
I asked about this tummy pain, abdominal swelling, genital swelling, and cellulitis. For cellulitis also, I asked like anywhere you feel like ulcers or any swelling in the
You did not ask like ulcers. You asked no infections. I have written here. Yeah.
Okay.
You asked no infections, no problem in liver, no problem in heart, like this.
Okay.
I have one question, please.
Yeah. Thank you.
Okay.
Is it relevant to ask about family history of blindness to exclude Albert syndrome, or no need for that?
I think it's a clean case of meningeal disease. Still, we have to ask about the family history of kidney disease. But this if it is a new case, undiagnosed case, this would have been some relevant question. But I think in this scenario, asking about any kidney disease in family, that will be covered up these things.
But I think, Doctor, we don't know what about the history in the first episode, so we should ask all.
Yeah, many things like this. Like we can make it hundreds of lists. Still, like some relevant question I have missed, like it is a true relapse or not. Even 3 days, this urine albumin should be there. I did not ask that important questions because single days we cannot say relapse. That doctor has rightly mentioned. So many questions I missed. So I think that will be too far to go.
And I did not tell. But in the what it was given 4 days, there is started puffiness. That means every day the mother has checked. But you did not ask. That's why I did not say. But in the presentation, the child is presenting from 4 days. That means he has 3 days of 3+ urine. But still you have to ask. Okay. And some questions, Dr. Satish, it will waste your time. Some questions you asked 2-3 times, I believe. Like the increase in
one blood pressure question I asked double time because I don't know why I asked.
Yeah, you asked double time because it will waste your time. Okay, so let's see the baseline investigations and this for. The page number here, 219.
I don't know if he said lipid profile and serology for hepatitis B and C.
Let me open the page. No, he did not tell.
I was confused. Like, should I say all investigations on the fish for as of the first episodes, or in relapse I need to do limited investigation? So
I don't know because this is after 1 year,
this
right?
Investigation mentioned in Mark. One history of relapse and all this investigation mentioned.
Okay. Thank you. I will do the same. Thank you.
So this is the red book before definition and respiratory abdomen. We will just go through from the investigations. You'll start from the investigations and immediate management, because this case can also come as a video station. Okay. Rest all, I think it's okay for us. The recognition, symptoms and signs, it's okay. We can read ourselves. Let's just go for the investigations. Okay. See, this is very important point. Remember, they can ask you. Okay, femoral blood sampling is contraindicated because of risk of thrombosis in these patients. Okay, just remember, if something is highlighted like this will be their favorite question. Okay, femoral blood sampling is contraindicated because of risk of thrombosis. So in urine analysis, early morning urine protein creatinine ratio first morning after admission. So you will do early morning. This Dr. Krishna was telling, which you did not tell Dr. Satish. Early morning urine protein creatinine ratio first morning after admission. Okay. Now what is the normal value? You should know, less than 20 mg per millimoles. In nephrotic, it will be more than 200 mg per millimoles. Usually more than 600 mg per millimole. Okay, and low urine sodium less than 10 millimoles suggests hypoalemia. So two things will your urine protein and creatinine ratio in the early morning you have to do. So the normal value less than 20. In nephrotic it will be more than 200. Okay, and low sodium will give you the clue of hypoalemia. I don't know if you have to remember these values, but just remember more than 200 is for nephrotic, and low sodium, low urine sodium may show you hypoalemia. But if he asks interpretation, then only you will say, but mention this investigation, early urine protein and creatinine ratio. Next, baseline bloods. You told FBC and you told CRP because the child has infection, and you told albumin. But I think UE also you told, but you did not tell kidney function tests. I prompted you. You have to tell. Creatinine is very important. Okay. So urea, electrolytes and creatinine. On the whole, that is the kidney function tests, albumin, full blood count. Then immunoglobulins, GAM, complement C3 and C4, zoster immune status as baseline, hepatitis B and C serology. Now this, your doubt is, do we do all this for relapse? This is your doubt, right, Dr. Satish?
Yeah.
Who was speaking before, Dr.?
So I think in this scenario, since there is high pressure, so I should go for complement level for no doubt. But I'm thinking of just a immune status.
Because
like,
it was done 1 year back now. I think
yeah,
you have to
okay,
go.
okay,
You have to go for
okay.
everything.
Yeah.
And she said she's telling that there is a case of relapse in Mark, and he has mentioned all this. We can also go through it, no problem.
Okay, okay.
But whenever there is a case, let's do all these baseline investigations. Remember this, okay? So FBC, kidney function tests, albumin, complement C3, C4, zoster immune status, and hepatitis B and C serology, both varicella and hepatitis serologies, and then urea and creatinine and electrolytes. Okay, this will be our baseline. Now, request second line tests. You will request only features suggestive of more aggressive nephritis. Okay, what are these features? If the child has hypertension, but again, not one reading if it is persistent, as Dr. Rohel said. So hypertension, macroscopic hematuria, high creatinine, no response to corticosteroids. That is corticosteroids resistant, then hypertension, macroscopic hematuria, and high creatinine. If you see any of these features, you will go for second line tests. That is anti-streptolysin O titer and anti-DNase B, anti-nuclear antibodies, anti-DNA antibodies. Okay. So this 2 is for SLE, anti-nuclear antibodies and anti-DNA antibodies. And this 2 is for streptococcus, post-streptococcal glomerulonephritis, that is anti-streptolysine O and
Yes,
anti. Mute all. 1 minute. So interpretation: high hematocrit suggests hypoalemia. Raised creatinine or urea suggests hypovolemia, tubular plugging, and other nephritis. So raised creatinine and urea, that is renal insufficiency, can suggest hypovolemia, and also there is some nephritis features and tubular plugging. And hematocrit, raised hematocrit also will suggest hypovolemia. Serum cholesterol and triglycerides often elevated. IgG usually low, C3 normal. So should we go, this of the cholesterol and triglycerides is not mentioned here in the investigations.
Yeah, we should go in on the first at the time of diagnosis.
What
Because
about relapse?
diagnostic criteria? Relapse, I don't know, but at the time of diagnosis, because one of the criteria,
Yeah, it's not
hypercholesterolemia,
mentioned. We should tell this, okay? Serum cholesterol and triglycerides, very important.
if not done previously,
Yeah.
like this, we can mention.
Yeah, that's why you have to review the child's record. Then immunoglobulin G, A, and M, all immunoglobulins also should be covered, and C3 will be normal. Next, differential diagnosis, minimal change disease, 95% of the cases. Focal segmental glomerulonephritis, here we cannot tell. All these things are microscopic diagnosis. So you will tell what differentials we said, like in the history you will give after nephrotic syndrome, maybe angioneurotic edema or nephritic syndrome or CCF and chronic liver disease. This will be our differentials. So minimal change disease, focal segmental glomerulonephritis, multi-system disorders, HSP, diabetes mellitus, systemic lupus erythematosus. If there is rash going, if there is in the description rash going with typical of SLE or something, you can put these diagnosis, because but in our case there was no rash. Okay. Congenital nephrotic syndrome, very rare and seen in under 2s. So immediate treatment, general, admit. So usually you will admit these patients. Okay, I don't know about relapse. Relapse also you will admit.
I think until the remissions we have to admit. They have written somewhere like until the remission. If consultant asks you the consultant regarding if you have to discharge early, right? Somewhere it is written in the book. As far as I remember, I didn't remember like it is the thing we are doing regularly, UPC ratio. I just miss it because I was more focused with the student card and all these things. The mind becomes very bland.
Yeah. If we give
Do
the
we need to admit patients with nephrotic syndrome without any complication? Yeah, malab, do they admit?
I don't know,
Admit,
maybe
yes.
at least
Yeah, admit.
okay.
Admit. First time is admit. Yes.
Who said what was the comment before you said admit?
Admit, yes, admit.
Okay, admit strict fluid balance monitoring. Yeah, you will monitor the fluid balance. Daily weight is mandatory. This was not told, Dr. Satish. Just concentrate on what you left, okay? Daily
Yeah.
and avoid added salt, but low salt diet not indicated. So avoid added salt, low salt is not indicated. Manage hypovolemia. So we will go to complications for that. Seek senior advice before volume resuscitation as risk of volume overload. So whenever the patient is in shock, first thing you tell, you will consult your consultant. Okay, before doing anything, because here there is due to in volume resuscitation there is risk of volume overload. So senior advice before you start. Okay, the main thing here is you will admit fluid balance monitoring, weight monitoring, added salt should be avoided, but low salt is not indicated. And for whenever the child is in hypovolemia, for volume resuscitation, you will contact your senior. Okay. Then fluid restriction, restrict to insensible loss, 300 ml per meter square plus urine output. If not tolerated, aim for 600 ml per day in children less than 5 years, 8 ml per day in children 5 to 10 years, 1000 ml per day in children aged 10 years. So you will just give this as, regular, you will give the fluid only 300 ml per meter square, plus you will check the urine output and add to it. This is what I'm understanding, right?
It's difficult to remember actually. We can say like insensible fluid restrictions to previous day output plus insensible water loss. Insensible water loss is 300 ml per meter square. This is like I don't think I can remember this in exam. Extra than that.
Urine output you will be calculating, right? You will be collecting the
yeah, last 24
output.
hours output plus insensible water loss.
Oh, that's it. Okay.
Yeah.
Okay, and they have made what do they mean by if not tolerated? That means the baby is not taking by mouth the fluid.
Yeah, I think yeah.
And then they have made this as okay. I think this will not be asked. It's okay. So medication 60 mg per meter square oral once daily in the morning. CBNF for surface area. Then phenoxymethylpenicillin for pneumococcal prophylaxis. Presentation only. I think for the first time you will give this.
Like somewhere it has written like until the edema subsides, but I don't think it's like next page somewhere it has antibiotics to be given until this edema subsides. But we can at least we have to mention like on this antibiotic penicillin B for pneumonia prophylaxis.
But you did not say, Ra?
Yeah, I did. I missed many things in management. I'm realizing. And yesterday only I read it.
I don't know. Really, we will forget things in the exam. Yeah. Okay. Anyways, prednisolone once daily. Then phenoxymethylpenicillin for pneumococcal prophylaxis. If edema upsetting to patient or causing discomfort, you can add furosemide 1 to 2 mg per kg oral or 1 mg per kg IV over 10 minutes. Okay, if edema is distressing the patient or causing discomfort, you can add oral or IV furosemide. May intensify hypoalemia, in which case use albumin 20%. Discuss with consultant or specialist center. Okay, this furosemide you add can rapidly cause hypoalemia. So in which case you have to consider albumin 20%, but for all these things, you will involve your consultant. If disease is severe, especially with hypoalemia as judged by poor perfusion, high HB, thrombophilia or abdominal pain, treat with dipyramidol to reduce the risk of thrombotic complications. Discuss the need for heparin or warfarin with pediatric nephrologist. Give omeprazole for gastroprotection whilst on high dose steroids. So I think for all these, if there is any questions asked, we will tell. Basically, you will tell prednisolone and this penicillin V and omeprazole also. Okay, omeprazole for gastroprotection to prevent for high steroids. Rest all for this furosemide and adding albumin, you will consult your consultant. And if there is features of shock, definitely you will involve the consultant. Okay. And you will discuss for, if they ask about thrombotic complications, you will tell that you will involve the pediatric nephrologist, multidisciplinary team, rather than mentioning all these drugs. I think better to be simple. And all these decisions we will not take. It has to be taken by pediatric nephrologist. So for us is only this prednisolone, penicillin V, and omeprazole. So this penicillin V is given even in relapse, or what he is telling here, presentation only. Can someone clarify me about this? Hello?
Yep. I will be searching. You can go on. I will search other leaflets. If I get, I will notify you.
Okay. Okay, complications are very important. First is the hypoalemia, then is the peritonitis. This question of peritonitis can also be asked, okay, even in history or in video. Then cellulitis and thrombosis. These four complications you will remember: hypovolemia, peritonitis, cellulitis, and thrombosis. So let's go to hypovolemia. Abdominal pain, looks unwell, tachycardia, poor perfusion. So features of shock, but there will be swelling in the body. Abdominal pain, looks unwell, tachycardia, poor perfusion, high HB. Seek senior advice before volume resuscitation as risk of volume overload. So you will start 0.9%, 10 ml per kg. This was told by Dr. Satish, but before that you will involve your consultant. Don't confuse 4.5% albumin with 20%, as the latter is hyperosmolar and can easily cause fluid overload. Okay, so be clear which albumin you are giving, 4.5 or 20%. Start dipyridamole, looks unwell, abdominal pain, vomiting, low JVP, raising urea creatinine, and poor response to diuretics. Check with consultant first. So if all these features are there, unwell, you will involve the consultant. Salt, poor, hyperosmolar, albumin 20%. Okay, 0.5 to 1 gram per kg or 2 to 4 hours with furosemide, IV midway through infusion or 5 to 10 minutes. So you'll just tell that you will admit the baby in PICU in cases of shock, and you will start this hyperosmolar albumin with furosemide. Doses is not needed. Regular observation for signs of circulatory overload, that is raised JVP, tachycardia, gallop rhythm, breathlessness, SpO2. So you will monitor the child for circulatory overload. Here it was hypovolemia, low JVP, but overload will cause raised JVP, tachycardia, gallop rhythm, low SpO2. All these things has to be observed. Often require daily liaise with specialist nurse. Okay, then peritonitis can be asked. Difficult to recognize. Steroids may mask signs including fever or cause leukocytosis. So steroids may mask the signs of fever and also may cause leukocytosis, which may confuse you for the infection. And abdominal pain will be there. Consider hypovolemia and appendicitis. Request early surgical opinion. If there is abdominal pain, you can also suspect appendicitis in this patient. Obtain blood culture and peritoneal fluid for gram stain and culture. If possible, then start piperacillin with tazobactam, that is tazocine, IV pending culture results. So the preferred drug here is the tazocine after taking blood culture and peritoneal fluid if you suspect peritonitis. Okay, if penicillin allergic, discuss with microbiologist or consultant. Infectious disease. So for peritonitis, we have to remember this is the drug of choice, tazocine, but before that you will take blood cultures and peritoneal fluid cultures. If allergy to penicillins, you will discuss with the consultant. That's it. Next, cellulitis, commonly caused by hemolytic streptococci or pneumococci. You have to treat promptly cellulitis.
So what questions do I need to ask? How I need to ask about cellulitis? This is also an infection, also it's medical jargon. So what questions might be better?
Do you see any redness in the skin or any yellowish discharge from the skin like this? I think.
Okay.
Yellowish discharge will be like the purulent, right?
Yeah.
Yeah. So
painful swellings with discharge in the anywhere in the limbs, right? And this, okay.
Then for thrombosis, renal vein, an important differential in abdominal pain. So for abdominal pain, you can consider they may have appendicitis, they may have peritonitis, they may have this renal vein thrombosis. Okay. Cerebral vasculature thrombosis, also pulmonary vein, femoral blood sampling is contraindicated in these patients. A fall in platelets and rise in D dimers and reduced PTT. What are the investigations will suggest you is when you do CBC, fall in platelets. If you suspect thrombosis, I think you will also go for this PT-PTT and D dimers. Okay. So reduced PTT and rise in D dimers are suggestive. Ultrasound Doppler study to look at perfusion and to image renal vein, inferior vena cava can be helpful. If any doubt, seek advice of pediatric nephrologist regarding investigation and management. So any complications, directly you will refer to your consultant. Okay. I want to know about this drug. Okay. Does anyone has idea? What is this dipyridamole? Are they using in your centers or anything?
I think it's like antiplatelet medicines or
no, it is for hypoalemia.
To prevent thrombosis, actually. In hypovolemia, there is chance of hypothrombosis. So
maybe. Yeah, there is here, see, discharge policy and subsequent management. There is here for relapsing patients. What do you do? So for relapsing patients, our case, 3 consecutive days of 3+ or more early morning proteinuria having previously been remission is the relapse. So 3 days or 3 consecutive days of 3+ or more early morning proteinuria. So start prednisolone 60 mg per meter square once daily. Continue until nil or trace of proteins for 3 days. Then
that is a remission. Yeah.
Meter square alternate days for further 4 weeks. Gradually reduce the days aiming to stop after 3 weeks. That's what I want to tell Dr. Rohel. If he is out of proteinuria for 3 days, even if it is 2 weeks, the regimen will be changed to alternate day. Okay. So in the history, what I told him was 2 weeks daily.
No. What he said is like, this is a relapsing patient. In case of like when the history, when I asked the history from in the first episode also, the duration of treatment was just for 4 weeks, for 2 weeks only, but it has to be at least 4 to 6 weeks in the beginning and first episode.
Yeah, I got. Okay.
In relapse it's okay, but in the first episode it should be at least 4 weeks.
Okay, yeah, you are right. So yeah, I got to know. I was wrong. Yeah. So in the relapsing patient, we will start when we see 3 days of consecutive negative proteinuria. Right. Continue until nil or trace of proteinuria for 3 days. Then we will continue 40 mg per meter square alternate days for further 4 weeks. Gradually reduce dosing aiming to stop after 3 weeks. So 4 weeks has to be alternate day. Then further you will reduce to stop after 3 weeks. If relapse is frequent despite alternate day prednisolone, discuss with P. So frequent relapses, you will refer to pediatric nephrologist. Okay. Okay, for the new patients, you will give prednisolone 60 mg per meter square for 4 to 6 weeks, and then 40 mg alternate days again for 4 to 6 weeks. Then gradually reduce the dosing to stop after 3 to 4 weeks. Response usually apparent in 7 to 10 days. No response after 4 weeks of daily suggests corticosteroid resistance. Okay, this was told by Dr. All of you know this. Oral prednisolone, while on prednisolone 60 mg per meter square once daily, advised to carry a corticosteroid card. Okay. Yeah, you are right. You asked about the steroid card, but I told I don't remember. Because
I remember the corticosteroid card, but I forget urine protein creatine ratio, which I am doing regularly. So it's very obsessed with this exam. Actually, I'm forgetting what we are doing.
No. Next time when you go for the history, first write your differential diagnosis and try to ask the questions related to it. That is more important. It happens, it's okay. We cannot remember everything. So if the patient is on high dose corticosteroids, you will advise for them to carry a corticosteroid card. Seek prompt medical attention for illness, especially zoster contacts if not immune to zoster. So if there is any contact with chicken pox, it has to be immediately the medical advice has to be taken. That's why the baseline management here is zoster immunoglobulin has to be checked in these patients. Other management, urine testing, teach technique and provide appropriate dipsticks. Test only first daily urine sample. That is early morning, right? The mother has got that early morning urine sample, she has to check. So teach technique and provide appropriate dipsticks. Test only first daily urine sample. Keep a daily protein dairy and bring to every clinic attendance. You did not ask about dairy, but you would have asked not for this case. Now she's checking from 4 days only because she sees puffiness. But for the first attempt, you would have asked her, did she maintain dairy at that time? Okay.
Yeah.
Dairy is, I think, important for all the patients like diabetes, asthma, nephrotic, every patients. So you will keep a daily proteinuria dairy and bring every clinic attendance. Corticosteroid dairy with instructions regarding corticosteroid dosage. Both proteinuria dairy and corticosteroid dairy has to be maintained, and the technique has to be taught for the mother, and she will do every day early urine sample and keep the dairy for that. Okay. Then infectious precautions, avoid live immunization for 3 months after completion of treatment with high dose corticosteroids. This question also they can ask. Okay. So for how many months you have to avoid live immunizations after high dose corticosteroid treatment? So 3 months you have to avoid live immunizations after high dose corticosteroid treatment. Benefit of inactivated vaccines can be impaired by high dose corticosteroids. So similar delay is advisable wherever possible. Even inactivated can be delayed because the benefit will be impaired by them. Okay. Where not possible because of frequent relapses, give inactivated vaccine after shorter delay and check for antibody response. Even though you give inactivated vaccines, you have to check for the antibody response. Okay. Continue phenoxymethyl penicillin V prophylaxis until edema has resolved. Okay, so
this is like very difficult because edema takes long time to resolve. So how long will be continuing this?
Till the edema resolved, you will continue. Like in here we read before. If it is simple case, it will show response in 7 to 10 days.
Yeah.
It's a simple. Like if it is a resistant case, it will go up to 4 weeks. So you will just tell the same thing what he has told. Continue penicillin V until edema has resolved. That's it. The same thing you'll tell. If allergic, you will use azithromycin. If zoster non-immune, so doing the IgG for zoster is very important. If zoster non-immune, IgG negative, or on high dose corticosteroids, give IM zoster immunoglobulin. So if they are negative to IgG zoster immunoglobulins, you will give them IM zoster immunoglobulin. Okay, and also if they are on high dose, because they will be on high dose corticosteroids, this has to be covered. After definite zoster contact is infectious 2 days before onset of the rash until all lesions crusted over. Can be given up to 10 days after exposure. Contact consultant microbiologist on BV for release of varicella zoster IgG. A first sign of illness, give acyclovir IV. If you see any illness like if you suspect this is chicken pox or herpes zoster, you have to start acyclovir IV. Varicella vaccine, live vaccine available and should be given if suitable opportunity arises between the relapses. So 3 months after high dose corticosteroids, you can give the varicella vaccine. But before that, you are just using this IgG. You are not giving the vaccine because it's a live vaccine. Give pneumococcal vaccine if child has not received pneumococcal conjugate vaccine. So you will also ask particularly about pneumococcal vaccine in the history if you want, if the mother remembers. Okay. Varicella vaccine and pneumococcal vaccine history is very important, and any blood tests related to it you can ask. If they remember, they will tell, otherwise no. So when do you refer to pediatric nephrologist? Corticosteroid resistant disease, non-responsive after 4 weeks of daily prednisolone, but start discussion with specialist center in 3rd week, or if relapses frequently. I want to know, relapses frequently means how frequently? What do they mean by this?
This frequently relapsing nephrotic syndrome, I think more than 2 relapse in 6 month durations or more than 4 relapse in 1 year.
Okay.
Frequent relapser.
So corticosteroid resistant means it is non-responsive in 4 weeks. So in such a case, you will refer, and also the frequently relapsing, you will refer. Corticosteroid dependent disease, that is 2 consecutive relapses during corticosteroid treatment or within 14 days of cessation. Here, this treatment is not during the daily treatment. When you start reducing at that time, right?
Yeah, some books has written in such way, but yeah, might be, yeah.
Yeah, I think that is what. Not during the high dose. When you start reducing it, they will start relapsing. During the reduction of the corticosteroids, they start relapsing, or within 14 days of complete cessation. Significant corticosteroid toxicity. Okay, you see side effects of corticosteroids, and age less than 1 year and less than 12 years at presentation. So you can also remember, like Dr. Satish, when I asked, he told 12 months and 12 years. This is also good if you have 12 months and 12 years. So less than 12 months and more than 12 years at first presentation. Mixed nephritic or nephrotic picture, that is macroscopic hematuria, renal insufficiency or hypertension, low complement C3 and C4 and ANA positive. So all these things you have to, if you have forgotten, just read it again and refresh yourself, because I think everything we read is important. It can come as video station as well. Okay. So any comments before we end the meeting? Yes.
Thank you, Noor, from my side. It was a nice refreshment, and I missed many usual things I missed actually.
But I want to encourage you. No, you were good.
Yeah.
Not bad.
And then today we got like our exam schedules, and it's on 27th.
Inshallah, all the best for you.
Thank you. Thank you.
Inshallah.
Thank you.
May God give you success, inshallah.
Thank you. Thank you.
So whoever is the exam going, if you want to take up the cases, please message me. I will contact you personally and give you the messages. Okay, cases. Okay, now the chances for the September exam going people till their exam finishes. I want to ask, Dr. Satish, you checked this penicillin V, it is only for the first presentation?
Yeah, on presentations only. It's written, right? I'm not getting
Yeah,
anywhere.
in two places he has written, but only on presentation. I think so. We
Yeah.
will only for the first relapse. We will
Yeah.
need to go with other.
Yeah.
patients.
Yeah.
Okay, then. Thank you all.
Well, thank you.
Nice history. Thank you, Dr. Satish.
Thank you.